firstly we discussed with you 19th for our conference, and we now were just in a hurry to change everything. I'm sorry. Our doctors are coming in a few minutes, but yes. Everything I hope will be fine. We tried to prepare two presentations, one from the radiotherapy department and one from our medical oncologist, but our medical oncologist cannot participate today. So I hope that we'll be fine for only of our radiotherapists to show their case.
Yeah, that's be great, because we also have the radiation oncologist here team today, and also I myself is a medical oncologist, but we don't have any cases from the medical oncology team. So I think that yes, I think that the just cases from radiation oncology is just fine, because we have so many things to see, between us. So hope that we could have enough presentation to discuss today, because.
Okay, perfect.
And how about life in St. Petersburg? How about life, about the war, and about the COVID-19?
Regarding COVID, that's now, I think, fine. That's was stabilization in St. Petersburg, and we now have the government decision that we don't need to even to wear masks in medical organizations. Still, it's of course not the best decision not to wear it in oncological center for our patients, and we ask them to do that, but still the government say that's fine.
Yes.
Yes.
Yeah. So could we start now?
Let me check.
Yeah.
Татьяна Михайловна, как дела? Вы готовы? Можем начинать. Нажмите, пожалуйста, кнопочку на микрофоне, чтобы мы вас слышали. Там сейчас красненьким горит. One second, доктор Ибхан.
Yeah.
Нас слышно?
Теперь, да, отлично. Мы готовы или ждем кого-то еще?
Нет, мы готовы. Презентация наша загружена, да?
Вон, там он бросил на рабочий стол, она открыта сейчас.
Понятно. Ну, хорошо.
Начинаем.
Let's start. We are ready. I am glad to see you.
Yes.
Again.
Good morning from San Petersburg team. Good morning, Dr. Sarabran. Nice to see you again. So, Dr. Minh, em có thể giới thiệu cái team của mình ở tại đầu cầu ở cơ sở 2 giúp nha bác sĩ Minh, giới thiệu bằng tiếng Nga với họ hen.
Không từ cho hỏi là hôm bữa bác sĩ hẹn khi nào mà chưa hẹn hả?
Thúy ơi, Thúy yêu cầu các bác sĩ tham dự đó, tắt cái mic cho mình.
Muốn 15 tháng này á hả?
Em ơi, Thúy.
Dr. Pan, are we waiting somebody from your side, or can we start with our presentations? I
think that Dr. Minh will say something to introduce our team, because our radiation oncology team for head neck cancer is different from last team for the general radiation oncology team is a little bit different. So I asked Dr. Min could introduce in Russian about our team at the hospital. Yes. So,
Thank you.
please, Dr. Man, yes, you can introduce our team.
Они хотят представить команду, да?
Наша команда сейчас содействует там доктор Хью и доктор.
One second, colleagues. May I just give a remark for our doctors? Татьяна Михайловна, у них отличаются команды по лучевой терапии для каждой нозологии. И, соответственно, тех доктора, которые представлены с нами сегодня, это другая команда. У них на каждую локализацию там вот есть по 2-3 врача, кто лечит, кто использует лучевое лечение для определенной локализации. Они хотят поэтому представить. Okay, please proceed.
Dokter еще раз, да, у нас там команда есть доктор Хью, доктор Ланфeng и доктор Хань из отделения радиации головы и шеи.
Understand. Thank you.
Пожалуйста. Начинайте, пожалуйста.
Нам предлагают начать, да?
Да, давайте, Татьяна Михайловна, вы показываете.
Так, подождите, а где, что-то я это самое забыла, как мы управляем этим?
Мышой.
Мышой, да.
Мы управляем, только я забыла нажимать.
Ну, слушайте, давайте, чтобы с нами кто-то был, тот, кто может управлять.
Да, это
потому
правда.
что это наши же.
Конечно, я просто не успела еще пронюхать все тонкости.
Так, где... Вот.
F5 можно просто нажать на клавиатуре.
Do you see our presentation?
Да, все хорошо.
Very nice to see you again. And today we would like to discuss the radiotherapy for head and neck cancer. All our team have experience of radiotherapy of all the localizations of head and neck cancer. In 2022, 366 patients with head and neck cancer were treated at our department, most of them with larynx cancer, 25% with cancer of oral cavity, 18% with oropharynx, and others with other pharynx and hypopharynx and others. So the workup for staging and diagnosis of squamous cell carcinoma of head and neck include general and local and regional assessment.
Linh thì chị không thấy. Giờ
Do you see and hear? Yes. And for oropharyngeal cancer, the examination of HPV status is necessary. And also for the assessment of distant metastases include a PET-CT or chest CT. Pre-treatment preparation include fixation of head and neck and shoulders with mask, the CT simulation, the fusion with MRI and PET-CT, delineation, and the dosimetry planning. 65% of patients irradiated in 2022 received definitive chemoirradiation or radiotherapy, and 35% received post-operative radiotherapy with chemotherapy or without chemotherapy. We have different radiotherapy options, including conventional fractionation, a moderate hypofractionation, radiation with a simultaneous and integrated boost and sequential boost. Chemotherapy usually include cisplatin 3 weeks. When there are contraindications for cisplatin, cetuximab is employed. So the schedules of radiotherapy are different. Usually it is conventional fractionation, and sometimes it is simultaneous boost with moderate hypofractionation and sequential and simultaneous boost. We have some experience of brachytherapy of the residual and recurrent tumor of oral cavity, of the tongue, of the floor of the mouth, but we use this technology very rare as we have the stereotactic irradiation. Supportive care is available during the radiotherapy, including nutritional support, laser therapy of mucositis and dermatitis, and metabolic correction agents. We would like today to introduce you 3 clinical cases of radiotherapy of oropharyngeal and hypopharyngeal cancer. The treatment of oropharyngeal cancer is based on the testing of HPV status, and for some patients with early cancer without metastasis to lymph nodes or with a single metastasis less than 3 centimeters, radiotherapy alone is used. For more advanced stages, chemoirradiation is introduced. These patients are operated rarely, and management for hypopharyngeal cancer is based on the ability of larynx preservation. It's radiotherapy or chemoradiotherapy, and it is important to the response for the induction chemotherapy for locally advanced hypopharyngeal cancer. And now my colleague Roman Lisander will introduce you 3 clinical cases. Thank you.
Hi, colleagues. Let me present you our clinical cases of treatment head and neck localization tumor. Clinical case number 1, patient N, male, 15 years old, squamous cell carcinoma of oropharynx, T3 and 2, M0, stage 3, G2 HPV positive. Methods of treatment VMAD with SIB up to total dose 17 grays, 35 fraction, 2 gray per fraction, plus chemotherapy cisplatin, 100 milligrams on square meter, cycle once per 21 days. In GTV-P and GTV-N volume, we include tumor of left tonsil invading the left lateral pharyngeal wall and lymphonodules with metastatic left level second. In CTV-17, we include GTV-P and GTV nodulus with margins. In CTV-16, including intermediate risk, including ipsilateral soft palate, ipsilate base of the tongue, ipsilate glossotonsillar sulcus, lymphonodules level second with metastatic. CTV low risk includes lymphonodules level third, fourth on the left, plus lymphonodules level second, fourth on the right. When calculated the radiation therapy plan, we observed recommended radiation doses for the critical structures, with the exception of salivary glands, which was due to the irradiated volume. During the treatment, the patient had mucositis of the second grade, as well epidermitis of the first grade.
Там был полный текст, нет?
Там не было данных. Case number 2, patient S, male, 67 years old, with squamous cell carcinoma of the hypopharynx, T4 and 2M0, stage 4A, status of PDL1 18%, HPV negative. Patient had 2 cycles of neoadjuvant chemotherapy, cisplatin, fluorouracil plus pembrolizumab, technique IMRT, sequential boost, up to total dose 17 grays, 35 fraction, plus cisplatin 100 milligram on square meter, cycle once per 21 day. GTV primary and GTV nodulus include tumor of hypopharynx, plus metastatic lymphanodulus third and second level left. CTV high level is GTV primary plus GTV nodulus with margins. CTV intermediate risk, including larynx and lymphanodulus left, second and third levels. CTV low risk include lymphanodulus level 35 left and lymphanodulus right levels 3rd, 4th.
Прокомментировал. План-то покажи. Есть какие-то комментарии по плану?
По плану нет такого.
А почему clinical goals? Я же просила, чтобы прокомментировать. Here, the symmetric plan with clinical goals, and you see the distribution of those.
When calculating the radiation therapy plan, we observe recommended radiation dose for the critical structure, exception of larynx and exception of larynx and thyroid.
It is irradiated, of course. Larynx is irradiated.
According to the result of the patient MRI after 8 months of treatment, patient has post-radiation change and clinical complete response. Clinical case number 3, patient B, male 17 years old with squamous cell carcinoma of the hypopharynx invading the supraglottic larynx, T4 and 2M0, stage 4A, HPV negative. Treatment up to total dose 17 grays, 35 fraction, plus cisplatin 100 milligrams on square meter, cycle once per 21 days. GTV primary and GTV nodulus include tumor of hypopharynx with supraglottic larynx, plus lymphanodulus neck with metastatic second and third level right. CTV high risk GTV primary plus GTV nodulus with margins. CTV intermediate risk including hypopharynx, larynx, plus lymphanodulus right level, second and third level. CTV low risk include lymphanodulus right level 4th, 5th, plus lymphanodulus left level 2nd, 4th. According to the CT scan prior to radiation therapy, the patient was diagnosed with hypopharynx tumor and a conglomerate of cervical lymph nodes of second and third levels on the right. The translate size to which is 38 millimeters. Based on the CT scan results, we have completed the following treatment plan. After the radiation treatment, which summary dose was 30 gray and 1 cycle of monochemotherapy with cisplatin, there was a reduction the tumor volume in the conglomerate of cervical lymph nodes. This result allowed us to make a further treatment plan with decreasing volume of radiation and reducing dose of radiation therapy on critical structure.
Yeah,
According to the result of the patient MRI after 9 months of treatment, we can see post-radiation change and clinical complete response. Thank you.
Thank you for your attention. I must say that the last case is maybe it will be better to perform the induction chemotherapy and then chemoradiation. And besides, there is the problem of the necessity of lymphodissection after the chemoradiation, even in the cases of complete response for patients with so large metastases to the lymph nodes, neck lymph nodes. Maybe after your presentation, we'll discuss this problem. Do you have any question?
Như vậy thì chúng ta có cái câu hỏi nào cho cái trường hợp của cái ca lâm sàng của bên phía Saint Petersburg không? Xin mời các bác sĩ khoa xạ. Nếu mà nói không được tiếng Anh thì các anh chị có thể nói tiếng Việt để mà bác sĩ Minh dịch qua tiếng Nga. Bác sĩ Hồng có ý kiến gì về cái ca trường hợp của bên đấy không, bác sĩ Hồng? So I'm asking our staff here for any comments or any question for your cases or also your presentation. So please wait for a while, Dr. Salamura.
Вопрос спрашивает, да?
Em ơi, mấy bạn ơi, có câu hỏi nào?
Yes. Thank you for your presentation. I see you control your clinical scale really well, the target volume, and similar with the concerns with you. So I had some question about your hypopharyngeal cancer. The first, I don't know do you test the endoscopy, esophageal endoscopy? Because the hypopharyngeal cancer, we had the synchronous esophagus about 10%. The second question, do you
maybe please have questions one by one, okay? So
yes, I'm sorry. The first question, I want to ask you, do you have the esophagus endoscopy for the patient with the hypopharyngeal cancer?
Татьяна Михайловна, поняли вопрос?
Ну, я поняла, что эндоскопия, только на каком этапе?
Просто для пациентов вот с этим каким-то...
Hypopharyngeal, да, yes.
Используете эндоскопические методы, видимо, для диагностики?
Yes, and endoscopy is used for patients with hypopharyngeal cancer and before treatment and also after the treatment to confirm the response for the treatment, yes. Do you answer your question? Have I understand you? You ask about endoscopy for patients with hypopharyngeal cancer, yes?
Yes, because in my opinion, I say the patient with the hypopharyngeal cancer, the patients with the second cancer is the esophagus cancer. In my clinical practice, we do the esophagus endoscopy, the routine for patient.
I understand you, but I understand. No, we don't use it for to exclude the cancer of the esophagus. Only if patients have some signs, any признаки. Signs of esophageal cancer, but usually we don't perform the endoscopy of the esophageal. Yes, only hypopharynx. Thank you. And the second question.
A second question: why you choose the regime for the induction therapy? We use the pembrolizumab. In my opinion, induction therapy, the first choice is the TBF. We chemotherapy with taxane, cisplatin, and 5-FU. The pembrolizumab we have for the patient with recurrent metastasis. Some cases in my department, we have induction therapy with TBF for 2-3 cycles.
Okay, I agree with you, but the decision of induction chemotherapy and is taken by the chemotherapist, and only after induction chemotherapy is finished, radiotherapist made the decision of the next treatment. So sometimes it is the protocol of investigation, and that's why this kind of chemotherapy was employed.
Она просто сказала, что у них пациентам только с распространенным процессом, с метастазами в кости.
No, it was the decision of chemotherapist, of oncologist and chemotherapist. Thank you. Do you have any more question? Maybe we'll discuss your presentation. We'll see your presentation.
I want to ask you about in my department, our team have the option about your clinical scale. I see your email. I see your control for the patient Ivan oropharyngeal cancer. I have we have some option for your control. I will show you.
You have question about our delineation of our patient, yes?
Она хочет показать что-то, комментарий какой-то по поводу этой моей разметки.
Yes. Okay.
I don't have any question to him.
Am I right to understand that you would like to show us some contour?
Yeah. So now, please, Dr. Phương, could you present the presentation and also your case? Thank you.
I'm pleased to attend this meeting. Then today, I would like to present the epidemiology of head and neck cancer in Vietnam according yes. epidemiology Vietnam, according to the data of the local. It's clear the most common cancer in nasopharyngeal cancer with about 6,040K. The ranking the 9th among on the common cancer, the followed by the thyroid cancer, hypopharyngeal cancer, lip and oral cancer, larynx cancer, oropharyngeal cancer, and salivary gland. In the biomarkers, according to the data in the 2022, we have the number of the head and neck cancer scale were about 1,744. While the highest number was still the nasopharyngeal cancer. The number of the cancer, the renal or disease, revested oral cancer, oropharyngeal cancer, larynx cancer, hypopharyngeal cancer, and thyroid cancer and submedullary gland. The motivations were diagnosed at the advanced stage with the stage 2 about 28%, and stage 4 is 50%. Whereas the number of the individual at the early stage is only about 1/5. Our department has been implementing different radiation techniques such as 3D, IMRT, radiotherapy, and SPRT. In the 2022, there were about 1,700 cases with the external radiation therapy, where in one of these cases we handle with the IMRT radiation therapy, and the rest are admitted with the 3D technique. In my opinion, in my department, we have the Reiki therapy about 40 almost cases in the nasopharyngeal cancer. We have just the five cases do the Reiki therapy, almost case in the oral cancer. About the 2 years, we do the SPRT technique, almost 30K on osmosis with the early head and neck cancer or local region cancer. I want to the next we have a presentation about clinical scale.
Next, I will introduce a case treated in our department. A male patient, 67 years old, presented with short throat. He has no comorbidities. He has an average condition. Capacity score is 13. We find a left level 2 and 3 net knot dimension and 3 centimeter indurated and fixed. Endoscopy shows an esophagitis mass on the right side of piriform sinus, arytenoid cartilage, posterior pharyngeal wall invading the right side of valvular epilepticoid, part of tongue, posterior tonsillar villi. The biopsy specimen from the hypopharynx is squamous cell carcinoma grade 1. The esophagogastroscopy shows an ulcerative lesion in the lower third esophagus, starting at 30 to 40 centimeter from incision. The pathology is squamous cell carcinoma grade 1. Other tests such as abdominal ultrasound and chest X-ray is normal. Next ultrasound shows right level 2 and 3 lymph node and left level 2 lymph node metastasis. Dimension about 34 millimeter. The head and neck CT scan show a lesion on the right side of piriform sinus, invading the right side of oropharynx, valvular epileptica, posterior pharyngeal wall, post right coil. The right level The right level 2, 3, 4 net node metastasis and left level 2 net node dimension about 31 millimeter. The chest CT scan reveal an irregular mucosal thickening about 22 millimeter up a lower end of esophagus. The length was about 5 centimeter. We also find mediastinal knot in the anterior of carina about 17 millimeter. This is a tumor of esophagus. The patient were diagnosed as squamous cell carcinoma at hypophorin T3 and 4 and 2 M0 stage 4 and synchronous squamous cell carcinoma of esophagus T4 and 2 M0 stage 4 according to AGCCI classification. The patient was treated with pain control, placed endoscopic gastrostomy to improve nutrition, then condition chemotherapy with 3 cycles of scapolipin 5FQ regimen, then simulation and treatment blending, radiation delivery and monitoring, response evaluation by simulation. The patient with head and neck cancer usually use the CT simulation 2.5 millimeter slide thickness with intravenous contrast. The simulation scan extend from the top of the skull to the abdominal. The patient immobilized with a 5-point head and neck mass and shoulder vulva. Delineation of hypophorin tumor. The GTV include on gross tumor and net node. CTV 66 include the GTV expansions 5 millimeter margin. CTV 60 primary include the CTV 66 and entire subside of the hypophorin, the larynx from hyoid to rhizoid, past face of tongue, tonsils, re-epiglottic fat, and re-vertebral facial. The net node cover the CTV 66 and expansion 3 millimeter margin. The left node level 1, 2, 5. The right node level 2, 2, 4, and 5A, and node level 6. The CTV 54 primary include the CTV 60 and the mucosa of nasopharynx. The net node include the right node level 1B and 5B. Delineation of esophagus tumor. GTV include on gross tumor and not metastasis. CTV 50.4 include the GTV and extends 1 centimeter margins. CTV 45 include the elective node such as berry, esophagus, and mediastinal. The images of contouring CTV 45. The gross tumor extend 1 centimeter, cover berry, esophageal lymph node, and mediastinal lymph node. CTV 50 bone for show contouring of esophagus tumor, the same as CTV 45, but not include the lymph nodes. CTV 54 cover the entire subside of the hypophorin, the larynx, part of oropharynx, On bilateral neck knot. CTV 60 the same as CTV 44 except the right knot level 1B and 5B. CTV 66 include primary tumor and lymph node involved.
The next, I explain about the treatment of landing. The technique we use the second show SFB, the VMAT, the radiation scars with the 2x2 rate daily fraction with the 5 day with the time of treatment in the circuit. We have 3 plan. The plan 1, plan 2, the plan 2 we have 25 the fraction. We use the for BTV 45, BTV 50.4 and BTV 54. We use the fraction 1.8 rate with the 25 fraction. The total dose is for 45 rate. For BTV 60 and 40 BTV 66, we use fraction 2 rate and fraction 2.2 rate. Of the second plan, we had just the 3 fraction. We don't treat for BTV 45. We just treat BTV 50.4 and BTV 54, BTV 60 and BTV 66. And the third plan with the 2 fraction, BTV 54 gets the 3.6 rate, and BTV 60 rate get the 4 rate with the 3 rate per fraction, and BTV 56 get 4.4 rate with 2.2 rate per fraction. We use the VMAT technique, the VMAT. For the first lane and second lane, with each lane we separate 2 small lane with 2 different isocenter. The one isocenter for radiation therapy into the hypopharynx, and not another one is for radiation for into the esophagus. And the plan, the third plan is only radiotherapy to the hypopharynx area. Is isodose for 45 rate. We have the cover. The on-smart, the tumor dose and orange dose are in accordance with the recommendation. The isodose for 54 rate cover nasopharynx cancer and hypopharynx cancer and lymph node. Just for the 60 rate, just the cover oropharynx region and hypopharynx and larynx. For BTV 66 rate, just focus Ross tumor. Thank you, your extension. Do you have any question?
Татьяна Михайловна, все ли было понятно? Есть ли какие-то вопросы к коллегам? У вас только выключен микрофон, мы вас не слышим, если вы что-то говорите. Попробуйте, пожалуйста, на экране включить. Алин, мышку возьми на экране, левый нижний угол микрофон.
Слышно?
Да, теперь все
слышно.
Thank you for a very interesting presentation, and the case is very difficult, I must say. And what was the result, and what side effects were during the treatment? Side effects during the treatment and the result. Do you can?
Okay. Dr. Khan, did they get the question of Tatiana Sharabura? She asks if there were any side effects during the therapy, and what was the results of the therapy then?
Yeah, we understood well the question from Dr. Sharabura, and I could like to ask also for the case for Dr. Sharabura and also the cases of from our team, because do you often give the patient gastrostomy to supply for the food and the nutrition for the patient throughout the radiation course or not? Because our team is do the gastrostomy very often in our hospital.
Mm-hmm.
Да,
thank you. We sometimes use tube transnasal, but usually no, we don't use usually for patients with head and neck cancer. We don't use gastrostomy. For patients with esophageal cancer, if the operation will perform after the chemo radiation, then gastrostomy also is not performed. But when the dysphagia is severe, then we perform the definitive chemo radiation. Of course, gastrostomy at that time is necessary. And what was the result of your treatment?
Và như vậy thì về cái ca mà chúng ta trình bày với lại team của chúng ta đó, thì cái kết quả sau điều trị như thế nào ạ? Và có cái tác dụng phụ nào không ạ các bạn? Và sau đó thì chúng cũng xin ý kiến của các anh chị hiện giờ khoa xạ cũng đã có mặt, ví dụ như là bác sĩ Phan Thế Xuân, bác sĩ Minh Linh, bác sĩ Nguyễn Kỷ Cương hoặc các bác sĩ khác ở khoa xạ đầu cổ, là các anh chị có bổ sung thêm ý kiến gì không sau khi mà chúng ta nghe cái bài trình bày, cũng như là có cái câu hỏi có liên quan tới lại cái ca lâm sàng của bên San Petersburg không ạ? Xin cho ý kiến về cái câu hỏi của họ về cái ca của chúng ta đi. Xin mời bác sĩ Phương hoặc là bác sĩ trình bày. Yeah.
The patient don't have the side effect is that mucosal state rate 1 or rate 2. After 9 months, we do state for the patient. We have the patient we're going to get the complete response. But the patient have normal night state. I think we have normal night state after 10 months. After 10 months treatment.
The complete response from the tumor is esophageal cancer and from the hypopharyngeal cancer, yes?
We had the complete response for the hypopharyngeal cancer and esophageal cancer.
It's very good result, I must say. And I don't understand, do you irradiate the mediastinal lymph nodes for esophageal cancer, or it's where the lymph node of the paraesophageal space? What mediastinal nodes do you include in the irradiated area?
Cái lymph node mà
mình có xạ vào hạch vùng trung thất của cái ung thư thực quản không các anh chị?
The testiculum includes the medias lymph node. We have the just cover.
So, are there any long-term side effect of the treatment on our case? For example, is the difficulty in swallowing or other function, especially nutrition function of our case, Dr. Phương? possible the stenosis of the esophagus or anything like this?
But after the transplant, the patient have the normal pneumonistis, and his family get the discharge operation, and we have the lost information for the patient.
Yeah, it's very pity. Yeah.
Thank you. And please, what do you think? What is the main problem of radiotherapy of head and neck cancer in your practice? Maybe recurrent tumor, maybe side effects, early or late. What's the main problem?
Yeah. Cái khó khăn chính, cái vấn đề chính trong cái xạ trị đầu cổ của các anh chị là gì ạ? Cũng xin ý kiến của các anh chị, thêm các anh chị khác, nếu mà các anh chị khác có ý kiến thì xin cứ bật mic lên và bổ sung ý kiến. Các anh chị có thể nói tiếng Việt, bởi vì chúng ta có bác sĩ Minh có thể dịch sang tiếng Nga, cho nên các bác sĩ của khoa xạ, ví dụ như là bác sĩ Xuân, bác sĩ Minh Linh, hoặc là bác sĩ Hà, cũng như là một số bác sĩ khác, thì có thể cho thêm ý kiến. Không, xin mời bác sĩ Phương.
In my case, it's the difficult to the set up patient for before treatment or radiation therapy, because we have the plan, the last field. We just separate the two plan with two isocenter, with isocenter for hypopharynx region, and the isocenter for esophagus. We had the two lane. I worry about if the setup would get error. We had the overdose in the field. We had the overdose in the field. The gap in the field in the gap. You should CT combine every day to the verification for the patient.
Thank you. I understand, but I would like to ask you about the main problem of radiotherapy of head and neck cancer. I must say that in our practice, one of the problem is the recurrent tumor, and I would like to suggest you to discuss next time the secondary radiation and the type of radiation, brachytherapy, stereotactic radiation, or conventional radiation for the recurrent tumor. And I would like to suggest you to write the questions before our meeting for better understanding. What about my suggestion? Настя, я предложила им в следующий раз обсудить лучевое лечение рецидивных опухолей и обменяться вопросами заранее в письменном виде.
Dr. Khan, I will just comment once again the proposal of Dr. Shirabura. She proposes to discuss next time with our colleagues the irradiation of the metastatic tumors of head recurrent tumors of head and neck.
Recurrent head and neck tumor after previous irradiation.
Which were irradiated before, as she said.
Yes.
Did you get it? The recurrent tumors which were irradiated before, and then also to exchange the questions before the meeting, just for colleagues to prepare and to answer these questions correctly.
Yes. So, which region do you specify for the re-radiate for the patient? Which region? Head and neck?
Any region you like. Any region you like. Maybe head and neck. I tell about head and neck cancer first of all, and in head and neck, any region.
Yes, so because at the Ho Chi Minh City Oncology Hospital, we divide the radiation oncology into three teams. The first one is gene team. The second is head and neck team, and the third is the general radiation, including the chest and the abdomen for the rectal, for example. So we have the three departments. So if you want, we will start with the radiation for the head and neck cancers first, right? For the radiation, yeah, for the recurrent ones.
Yes.
So, yeah. And do you have any comments for the case? Any question or to focus on our today's topic? Do you have any question, comments?
Oh, we don't have any more question. I think that this meeting was very useful for us, and I only suggest to continue.
Yes. So once again, we thank you for that. So về phía Việt Nam của mình, về phía đoàn của bệnh viện Ung Bướu chúng ta thì chúng ta còn có thêm câu hỏi hoặc là thêm ý kiến gì không ạ? Xin nhắn lại với lại các anh chị ở khoa hiện giờ là xạ đầu cổ là xạ 4 phải không ạ? Thì coi như là chúng ta sẽ có cái chủ đề cho cái đợt sinh hoạt lần tới sau 1 tháng nữa. Chúng tôi sẽ cho cái ngày sau là về vấn đề về xạ trị cho những tổn thương ung thư đầu cổ tái phát đã được xạ trị trước đó. Thì coi như vậy thì các anh chị xạ 2 là xạ trị đầu cổ. Dạ. Thì như vậy thì các anh chị có đề xuất gì về cái buổi sinh hoạt sắp tới không ạ? Như vậy thì cái chủ đề mà chúng ta dự kiến cho cái sinh hoạt sắp tới thì nó có phù hợp với các anh chị không ạ? Yes.
Thank you. I interested. I'm interested for recurrent cancer. We worry about for the treatment for the recurrent cancer because we have the overdose for the organ at risk. You should have visit. You should have the visit in the meeting.
So we have one thing here. So before the meeting, I think that at least 2 weeks before the meeting, we should exchange the problem, the question first, in order to help the other side clarify how we cope with the situation in real life.
Yes.
So now I think that in the next 2 weeks, both sides prepare for the problem-oriented radiation for the recurrent head and neck cancer, and after that we exchange the idea together in the same WhatsApp group. Do we agree for that?
Yes, of course.
Yes. So once again, if you don't have any question, comments on our today's topic, so I think that we will end this section here. It's a 1-hour section. Do you agree for that, Dr. Sarabura, and also Mr. Anastasia?
Татьяна Михайловна, все верно. На сегодня заканчиваем, да?
Да, yes. I don't have any questions.
Thank you, Dr. Khan. That was really interesting meeting. Thank you for your preparation, and we do hope to see you soon and to exchange the materials in next 2 weeks for the next time.
Yes. Once again, thank you for your participation and also for sharing your experiences on also the cases, very interesting cases from your team. And I hope to meet you in the next 4 weeks to discuss more about some problem on the head and neck cancer radiation for the recurrent head and neck cancers. And once again, thank you and have a good day.
Thank you. Have a good day.
Have a good day.
Bye. Thank you.
Bye bye. Cảm ơn các anh chị, cảm ơn các anh chị bên phía Việt Nam đã tham gia. Xin cảm ơn.
Спасибо, до свидания.
До свидания. Bye-bye. Bye-bye.
Bye.
По-вьетнамски выучили. Самое. Bye-bye.
Я только